Good afternoon. Thank you for joining this Heritage Foundation webinar on treating COVID-19, supporting front lines with real-time information. My name is Nina Ocharenko-Schaefer, and I am a Senior Research Fellow in Health Policy at the Heritage Foundation. In April, the Heritage Foundation launched the National Coronavirus Recovery Commission to provide the American people and policymakers with recommendations to move toward recovery. As part of its recommendations, the Commission has highlighted the importance of frontline clinicians sharing emerging information about the virus in real time. Today, we will discuss what frontline clinicians are currently observing with the COVID-19, how these new understandings are changing their treatment of the disease, and what policymakers could do to help frontline clinicians better communicate this information to other clinicians and to move more quickly to update best practices. Before we get started, I'd like to cover a few housekeeping items. First, all attendees are in listen-only mode. Second, we welcome and encourage your questions. They can be submitted through the questions box on your GoToWebinar dashboard. And finally, this session is being recorded and it will be emailed and posted on heritage.org/events within 48 hours. Now it's my pleasure to introduce to you Bob Moffitt, Senior Fellow in Health Policy at the Heritage Foundation. Since April, Bob has led a group of clinicians to help advise the Commission on its recommendation. Bob, I'll turn it over to you.
Thank you very much, Nina, and welcome, ladies and gentlemen, to this special webinar on a vitally important subject, which is how physicians are battling the virus on the front lines. As Nina mentioned, Heritage Foundation President Kay James is chairing an independent National Coronavirus Recovery Commission with 17 top experts from academia, business, and the healthcare sector of the economy. In assisting that effort, Heritage pulled together an advisory group of medical professionals, including one of our guests today, Dr. Brenda Fitzgerald, who is a former director of the CDC, as well as Dr. Daniel Johnson, the former president of the American Medical Association. The Commission adopted a key recommendation of our advisory group, and that is that the CDC improve the rapid flow of clinical information and facilitate a timely communication among physicians who are on the front line battling this virus, not only to improve their understanding of the disease, but also learning how to treat it. The recommendation grew out of a briefing from our second guest today, Dr. Thomas Gallagher from Providence Cedars-Sinai Medical Center in California. On April 7th of this year, Dr. Terrence McGuire, a prominent Maryland physician who previously published on viral infections, alerted me to Dr. Gallagher's work in California, particularly his finding that COVID-19 patients can generate a severe and deadly autoimmune response and that proper treatment could save countless lives. Dr. Gallagher briefed Heritage's medical advisory group, and we transmitted that information to the Commission and also to senior officials at the Department of Health and Human Services. Dr. Gallagher is the medical director of the Intensive Care Unit, a group of 20 physicians at Providence Cedars-Sinai Medical Center in Tarzana, California. He received his doctorate in medicine from the University of Southern California and his bachelor's from UCLA. Dr. Brenda Fitzgerald was the 17th director of the Center for Disease Control and Prevention, and also served as the Commissioner of Public Health for the state of Georgia. She received her doctorate in medicine from Emory University, her bachelor's from Georgia State University, and she is a proud veteran. She was in the States Air Force. Right now, I'll turn this over to my friend and a great colleague, a newfound colleague, Dr. Thomas Gallagher. Thank you.
Hi, good afternoon, and thank you, Bob, for that fantastic introduction. I want to personally thank the Heritage Foundation for giving me this opportunity to share my experiences in treating patients with COVID-19. I think my main takeaway point for all the listeners, and especially any of the physicians that are frontline physicians that are listening, is that this virus, the SARS-CoV-2, it can cause the disease COVID-19, but it's actually causing two distinct clinical syndromes. The first, as we all know, is an infectious disease, which is directly related to the virus. But more importantly is the second syndrome, which is an immune-mediated disease, wherein the virus activates the patient's immune system. And in a subset of these patients, the immune system goes haywire. And instead of the immune system attacking the virus, the immune system turns and starts attacking the patient's vital organs. Let me elaborate a little bit more into these two clinical syndromes. By this time, everyone in the world knows that the novel coronavirus SARS-CoV-2 causes COVID-19. This virus is a respiratory virus, and similar to influenza, it can cause pneumonia as well as respiratory failure. This feature distinguishes it from other viruses that cause the common cold. The symptoms that the patients have during the first week of their illness are the result of this infectious disease syndrome. The vast majority of the patients do improve, although there's 15 to 20% that get sick enough where they need to seek medical attention and subsequently become hospitalized. Within this group of patients who get very ill, there is another subset of patients where this immune-mediated disease manifests itself. In these patients, instead of the immune system becoming activated and working in a coordinated, concerted fashion to kill the virus, the immune system, again, goes awry. Now the patient's own immune system, which is designed to protect the body, is attacking the patient's healthy, vital organs and slowly killing the patient. This is a delayed reaction, and it usually manifests itself after the first week. So usually in the 7 to 10 days after the patient starts having symptoms. This is not an unusual reaction. We've known that other viruses can cause these types of reactions, these immune-mediated responses. But what's different is that SARS-CoV-2 is exceedingly proficient in inducing this immune-mediated response, and it does it in a very efficient manner. The symptoms that the patient feel, fever, cough, shortness of breath, are similar to the virus causing damage. So it's very easy and understandable for the doctors not to be able to differentiate between these two disease states. Also, the normal usual tests that we perform to help us differentiate when a patient is very, very sick, those are not really sensitive to pick up this immune-mediated disease. Everyone's immune system is as unique to them as their fingerprints. When the immune system goes haywire, not everyone has the same type of response. That's why every week we're hearing about a different type of disease that COVID-19 causes, whether it's blood clots that don't respond to normal therapy, whether it's a cytokine storm that produces a rapidly progressive respiratory failure, or strokes in young 30, 40, 50-year-old patients that shouldn't have strokes. And I think in the past week, we've heard about vasculitis and these types of Kawasaki-like syndromes that are occurring in children, which are obviously very, very serious. Now I'm an eternal optimist, and I think that there's always a silver lining. And I think the most important thing is that once doctors become aware of this immune process, there are tests that we do perform that let us know that this immune process is occurring. Once that it's diagnosed early, and especially once it is treated early and aggressively, it is absolutely treatable. Hopefully this can help us significantly turn the corner on this virus and make it more closely resemble to what we see during a normal influenza season. Thank you very much, and I'll turn it back to Nina.
Thank you so much for your insights and for your frontline work in this area. I'm sure many people will find it interesting and have some good follow-up questions for you as we get into the Q&A part. Now we'll bring in Dr. Fitzgerald. Please join us.
Thank you so much. It's a pleasure to be with you today. This virus is of particular importance for two reasons. One is how easy it is to catch the virus. The very first case of COVID-19 was reported in this country January 21st. Only 4 short months later, we now have over 1.5 million cases reported, and we have over 90,000 deaths. What's also been disturbing is in the journals of emerging clinical disease, emerging infectious diseases, there have been a lot of small reports that suggest that the virus can be transmitted when the patient doesn't have any symptoms. For example, in one German case that was reported, there were 14 colleagues that went to a typical business meeting. They did normal things like would go in the same cab. There were some handshakes, but none of them were symptomatic. Right after that, one of the persons became positive for COVID-19, and subsequently 11 of those 14 people also became positive. So this whole notion of how easy it is to get the disease is one of the reasons it is so important. The second is because of the deadly effect. Certainly the reports from the Chinese CDC indicate that 81% of the cases of COVID are mild and really don't seem to have any kind of bad consequences that we know at this time. But just as Dr. Gallagher reported, there are certain numbers that get very, very sick. In the Chinese studies, 5% of the population that had the virus became very, very sick. And of those, the Chinese reported that 49% of them died. So this whole business, if we listen to Dr. Gallagher, it certainly seems to indicate that those people that are getting very severely ill may be entering this second phase of the disease. And that if we really understand how to identify and treat this second phase of the disease, quite frankly, we could make a dramatic change in the survival rates. And the questions I'd like to ask Dr. Gallagher to sort of clarify some of your findings. You talked about the two disease states, and you talked about your recognition of the second disease state that you describe as so deadly. Can you tell us a little bit more about that, and maybe tell us before your team recognized that the kind of mortality things you were facing, and is there been any change since you've recognized that change in the disease?
Yes, thank you, Brenda. That's an excellent question. There's definitely a difference in terms of morbidity since we recognize that. The first few weeks, our experience was pretty much the same and similar to everyone else that's on the front line. The information we got was that when these patients become very, very sick, when they require a lot of oxygen, don't use any kind of modality to try to preserve them from ending up on a respirator. We were told to intubate them early because these patients are going to require intubation eventually. But within the first few weeks, we noticed that that was actually the wrong thing to do. These patients, when they end up on a respirator, they need prolonged mechanical ventilation. So within a couple of weeks, we had a lot of patients that were ending up on a respirator, and we were using a lot of our medications to sedate these patients. This was kind of the experience in New York, where they essentially kind of put a lot of people on ventilators and then eventually ran out of ventilators and, ran out of intensive care unit beds and had to, kind of to alternate. And then that's when we really started looking, because, these patients were crashing and it wasn't making sense. In my 20 years of experience, I hadn't seen this type of disease state. And that's when we started looking, and we're looking for inflammatory markers. And these are the markers that we don't typically check for. And we saw that those were elevated. And that's when we started treating these patients. Instead of putting them on ventilators, we started treating them with immunosuppressive medications, which was very counterintuitive, because you have a patient who got admitted to the hospital for a deadly virus. And now instead of boosting their immune system, you had to give them medications to suppress their immune system. And I think that was probably when we saw the biggest change. And since then, we've only had to put very few patients on ventilators. And again, if you diagnose it early and treat it early, you can make a big difference.
Thank you. And I know in our report, when you were giving us information, you said that your survival rates in your particular hospital following that protocol as compared to some of the surrounding areas has been dramatically different?
Yeah, so we take care of patients in 2 different local hospitals. Since COVID-19 broke out in early March, we've taken care of over 260 patients. 70 of those patients have been in the intensive care unit. We've had 24 patients that have expired out of those 260 patients, but 15 of them were what we call DNR, DNI. They did not want to be resuscitated. We've obviously, the past few weeks had, just like everybody else, had a large outbreak in local nursing homes. So, if you take out those 15 patients, it would be 9 patients out of 260. Each of these hospitals are part of large hospital chains and organizations, and within each of them, we are among the top in terms of our low mortality rates as well as our low ICU utilization.
And can you tell us, excuse me.
And I'm sorry, and this is also the fact that in neither of these hospitals do we have ECMO available, do we have what we call CRRT for continuous dialysis available, nor do we have prone beds available. So we're doing mechanical prone, where our amazing nursing staff, our dedicated respiratory therapists, we go in with as a team of 6 healthcare workers, and we manually take these patients, and we instead of being on their back, we put them on their stomach to help them with their oxygenation.
Once there's this transition from the first stage of the virus to the second, how quickly do they deteriorate?
Everyone is different, and that's the thing that it's been so difficult. You almost have to treat every individual patient differently. And what works for the first patient doesn't work for the second patient. So I've had patients where, they rapidly deteriorate within 12 hours, and I've had other ones where they do it slowly over a couple of days. And the treatment also is variable because, again, not everyone has the same immune system, and the disease that's produced isn't the same. I'm constantly fighting with some of the infectious disease doctors on my team who may want to give the same therapy to every single patient in the ICU. And the hard part about this is, what you give to one patient in the ICU will help that patient, but if you give it to the very next patient, it may kill the patient. So you have to go through a very, very rigorous evaluation, and really,
so
there isn't a one-size-fits-all.
the most important thing seems to be that what you need to do is you need to treat aggressively as soon as you recognize it, and you absolutely need to understand the disease process. Can you tell us how you've gone about making sure you have the needed lab test? At what point in the disease are you getting the lab tests you require?
So at this point, I've discussed this with our emergency room physicians, and they are very well aware of what lab tests. So as soon as a patient comes in and requires hospitalization, we order the lab tests. So we have it available at the very early stage. And then based on their clinical presentation and based on their laboratory, then we'll repeat it, whether it's every day or whether it's every 2 days. The first thing that I was taught in medical school was, don't be stupid, don't treat a lab, you got to treat the patients. So, the lab does not answer all the questions. You have to still assess your patient and see how they're doing clinically. And you have to integrate all the lab values that you have obtained.
Absolutely. But for those people out there who are not medical, the important issue here is that when a patient first presents, you not only do the traditional cultures for COVID-19, but you also draw the immune markers so that you'll be able to see when those immune markers change. So when it enters the second phase of the disease. So thank you very much, Dr. Gallagher. And Nina, if you'd like to open it up for.
Yes, Bob, I'd like to have you join back up with us so that we have a variety of questions that are covering the whole sphere, both medical questions and real just general everyday questions that people have about what's happened during this. I'd like to start off with my first question that's come in, which is how are physicians sharing this information today? What is the way that you are able to communicate to those within your hospital or those within your community? What are the ways you're trying to get the word out about what you're seeing on the front lines?
Nina, is that a question for myself or is that for Brenda?
I'm sorry about that. Yes.
You go first and then I'll follow.
Okay. I think that's probably been the hardest part about this virus. It's such a fast-moving virus, and we're already 2 weeks behind it. By the time the patient presents, we're already seeing it 2 weeks later than what's going on in the community. It's been difficult and it's been challenging. A lot of this early presentation, a lot of the early information was really kind of some emails that we got from physicians up in Washington, some presentations that JAMA put online for physicians in Italy, but it was not through the normal route where medical journals and those types of things. There's also a lot of web-based information that gets emailed to us physicians every day. Some of it is useful, but some of it is not very useful, and it's hard to kind of have enough time, as I'm spending 16, 18 hours a day to try to treat and organize our inpatient treatment for these patients. So it's been definitely challenging, to say the least.
Dr. Fitzgerald, would you like to add anything on how this information is getting communicated?
I'd like to speak now. One of the things that certainly placebo double-blind studies have been the gold standard for adding new medical information to the lexicon. Everybody understands that. But in this case, where we're facing a disease that has killed 90,000 of us in 4 months, we certainly need to think of a way that is still rigorous, that is not just depending on hearsay, but that is rigorous enough that we can make rapid moves in our understanding of the disease. That's why we decided to have this seminar today, because we think that there needs to be a national forum for those people on the front line, like Dr. Gallagher, like those people in New York, like those folks that are in Louisiana. Those docs on the front line that are coming to new understanding of this disease, we think we need to spread that information very rapidly. And we think that can be done with enough rigor that we can have faith in that and know that we can move forward on that medical information.
Are there, as a follow-up to that, and maybe Bob, you could chime in on this part, are there things, what's the proper role of the government in this sharing of information? And also helping to provide better best practices so that clinicians know what to do on the front lines faster.
I would just add that this is really a function of the Centers for Disease Control. I mean, frankly, when they get this kind of clinical information, what they ought to do is they ought to maintain a compendium of this information, and at the same time have regular briefings among clinicians on the kind of information that Dr. Gallagher and others are presenting to them on how this disease is developing. The fact of the matter is, several weeks ago, we did not know how any of this actually worked. Dr. Gallagher, in fact, is one of the first to actually identify, certainly, to identify this disease process, and the fact that the autoimmune system, this autoimmune response being so severe, was the source of a lot of very serious illness and death. So we're talking about life and death here, and I think it's really critical for the government in a case where we're dealing with a novel virus to make sure that on a very, very fast turnaround, regular basis, this kind of information is disseminated to clinicians on the front line on a regular basis. It has to happen because it's not a time where we can do the kind of detailed, gold-plated, as Dr. Fitzgerald has pointed out, double-blind studies, which take a long time. I mean, that's a great academic exercise. We haven't got time for that. We've got to move fast, and we've got to be able to take advantage of all these new developments. I thought that the New York case, where the 5 children died, and the first thing I thought of when I saw that in those newspapers is, my goodness, we had heard about this, basically the same kind of development from Dr. Gallagher back at the very, very beginning of April. And I'm thinking to myself, good Lord, how many people really understand this? I mean, I didn't understand it. And I think most of us who are in health policy, certainly those in public policy, do not understand a lot of this. We're dependent upon the medical profession to give us that expertise. but they have to communicate with each other. And that's, again, I don't want to overdo it, but that's where CDC has a primary responsibility, and they really got to step up to the plate on this.
I agree with that.
Great.
Immediately after we posted our webinar, I noticed that Medscape is a service that comes through. Lots of docs read it. It's emerging trends, emerging information. And I noticed that on Medscape, like tomorrow, Medscape is going to do a webinar on cytokine storm. The important thing that we need to do is that what that means is somebody completely separate from Dr. Yadigar's group noticed a similar thing. And if we're going to have, that's the rigor. If we have reliable physicians in different parts of the country that are noticing the same thing, we need a quicker way so we exchange that information. Again, in the last 4 months, 90,000 Americans have died, and we really need to increase our ability to exchange the clinical information and the clinical observations so that we bring this to a halt.
So now we'll shift to another question, a little bit in a more of a practical question here. If the immunosuppressants actually help, why was there so much public discourse about ventilators? And can data help with this kind of information moving forward? Perhaps either Dr. Yadigar or Dr. Fitzgerald could chime in on that. Dr.
Yadigar, you're on the front lines. Why don't you take that?
I'll let Dr. Fitzgerald take this one, and I'll apply secondly.
Well, I think when the disease was first presented, it was presented as a respiratory disease. And because of that, there was a lot, in order to prepare, the medical community started building up respirators because we were thinking in the terms of respiratory disease that we have seen in the past. And that was logical, but then we began to see a whole series of things that weren't explained by simple respiratory disease. And I think that I remember very clearly when Dr. Yadigar presented to us, he said, you know, we were having all these things. I didn't understand it. So I just got out all the charts and I looked at it and I said, what kind of disease, you said, what kind of disease process presents in this various modalities in all these different ways? And the only thing that made sense was an autoimmune disease. So I think that when we first heard of the disease, it came to us as a typical respiratory disease, something like flu, only worse. And it's true that it's 10 times more deadly than flu, but it is much more efficient, obviously, in activating this destructive autoimmune response.
Great, Dr. Yadigar.
Nina, I would definitely, I would definitely second that. You know, so within the first few weeks, again, we were kind of listening to our colleagues from China, from Italy, from up north in Washington State, and we're putting everyone on a respirator that required a lot of oxygen. And you know, we weren't using the measures, the conservative measures, to try to prevent people from ending up on respirators. And within about a 10 to 14-day period, we rapidly changed our treatment guidelines to the point that all of a sudden I started getting calls from my respiratory therapist, from the nurses. You know, 10 days ago, you told us that, you know, these patients are very, very contagious and they need to be put on respirators. Why are we using these modalities like high flow, like non-invasive ventilation? So I had to explain it to them that no, this, you know, putting patients on a ventilator, this isn't the therapy for these patients. This is actually just making the disease worse. And we had to quickly backtrack and change to where we treated the patient's immune disease and not their respiratory disease. And I think that's, again, for us, for our institutions, that's where it really made a big difference. And we've been doing that for over 6 weeks now.
Wonderful. Another question is related to, again, sharing of the information. And are you able to share, how are doctors sharing information outside of the construct of their own hospital? How are you for example, being able to share to the CDC? Are there pathways that are available for doctors to share that information directly with the CDC and inform their ability to design best practices?
There really hasn't been, from my personal experience. What I did first initially was I reached out to my colleagues in the local hospitals, but I came across a lot of resistance. This is obviously something that's very difficult to explain, even to a critical care physician. It's taken me weeks to explain it to the doctors that work with me. But to explain it to other doctors, they really didn't want to hear it from me. They wanted to hear it from the CDC. They wanted to hear it from the NIH. They wanted it to be associated with a randomized control study, which, again, I agree with Dr. Fitzgerald. There's always, that's the gold standard, and that's what we should always do in medicine. But when you have such a rapidly moving pandemic that's killing so many people, to organize and to perform well-controlled randomized studies takes months and months and months. It was very difficult, and it's been very challenging, and I haven't been able to get as much traction. And I'm hoping that this webinar with the Heritage Foundation will reach a larger group of people.
And again, let me emphasize that the whole idea of having a rigorous discussion, we're not just talking about an antidote. Just have a national discussion where all the doctors on the front line are able to come together and say, yes, I saw that, or no, I thought that at first, but then I found out. We really need, and that is not really the way that medicine is usually occurring. I know certainly in my small hometown, the docs who are infectious disease docs and head of the ICU here, they've been going on the internet, on social media and talking to their colleagues. But we really think that it is important that we have a national discussion for this, and that certainly probably can come under the auspice of the CDC. That's where I would like for it to occur, certainly, but there needs to be a national discussion. And I realize again that the standardized test, the random test will occur in the future, but we really need this frontline clinically important discussion to occur on a national level.
Wonderful. Another question kind of is looking forward a little bit. Do you see that there might be changes to how the virus presents itself in phase 2 of perhaps a new round that might be coming at a later time? And what that might look like, would it be for the best or could it get worse?
Well, I would say that phase 2s are actually already here. In phase 1, we saw a lot of patients that had community transmission, and those presented very differently. Right now, we're getting a lot of patients from nursing homes and assisted living facilities, and the presentation is significantly different. This is not a virus that's going to go away, as much as all of us are hoping and praying. I think it's going to be here with us, and definitely in the fall. If we're not better prepared, it's going to be much worse. But I think the presentations are, essentially what we're seeing. I don't think that it's going to rapidly mutate to a different virus altogether. But we're already seeing a lot of different variety of presentations in patients, and it has to do with whether they're coming from home and or whether they're coming from nursing homes and have a lot of other what we call comorbidities like diabetes, heart failure, COPD. So I think those are the two different presentations that we're going to see.
And the important thing, Nina, is if we have a format where there is a national discussion and a continued conversation between those people on the front line, new changes can be rapidly identified. Again, it needs to be rigorous. It needs to have checks and balances with physicians adding their experiences and being discussed at a level where some real changes can be made. But I think if you think of this disease, that is 80% it's mild And then there's this 5% that's critical. And we learn dramatically how to treat those critical patients. It changes the whole discussion. I mean, if you're looking at something that's going to kill 90,000 of us in 4 months, that's worrisome. If you're looking at something that the vast majority of us survive, that's a whole different dynamic. So I think the fact that the disease is going to be around until we develop the vaccines, and I'm very pleased with all the movement that's occurring in the development of the vaccines, that certainly needs to be done. But this whole business of learning the disease and learning how to treat it in a more, in a quicker manner, I think is enormously important.
Wonderful. Bob, I wonder if you could maybe elaborate a little bit and talk about with the balance of understanding that we do believe that doctors are really on the front lines and other healthcare providers in treating these patients. What is the right role to keep the balance between what the physicians want to do and the information they're sharing, and then the role of public policymakers, in particular that the balance between a federal solution and a federal strategy versus a state strategy?
Yeah, well, I think we've learned an awful lot over the past 4 months. One thing we've learned is that the federal system has actually given us some tremendous advantages. Federalism has got a teaching function. We've learned how different states have responded to the crisis in different ways, and we've learned that some have been very successful, others have not been successful. It is pretty clear, for example, that on the basis of the raw data, that Florida has actually done a better job than New York. The data shows that. It's not even a debate now. Some of our state officials have made some terrible decisions, perhaps because they simply do not understand the disease, and that is why ultimately, you know, the answers to all of this is going to depend upon the medical profession catching up with this and figuring out exactly how to deal with it. But, you know, I mean, we've seen we know now that, you know, I think something like 40 to 50% of the mortality from this disease is mortality from people who are very sick and in nursing homes. So we know that. I mean, that's enough to know. So closing down or quarantining communication or quarantining nursing homes obviously makes a lot of sense. They did not do that in New York. In fact, they were sending sick people into nursing homes for a while, and that had a negative effect on this. In Florida, they have been much more rational in their approach to this. So federalism, I think, enables us to see, you know, what works, especially in an area where the responses are not entirely crystal clear about exactly what the public health response should be. The founders of the American Republic, you know, they made a very, very rational decision about policy making, recognizing that states actually could pursue different policies, and we could learn from what works and what doesn't. Some states are innovative, some states are not. People ultimately get the government that they deserve, and the government they voted for, and the government they want. However, having said that, as a public policy matter, in terms of public health policy generally, that battles are being won, you know, on the ground in different states. The ultimate fact here is, and I think it's been crystallized by Dr. Yadigar's work, the work of other physicians, that this is ultimately going to be won or lost in the ICU. It's going to be won or lost in intensive care, and that's where the ultimate battle really is. And I think what it really means is public authorities have got to do everything they possibly can to give physicians the leeway to do what they think is best, and at the same time promote as much as possible what Dr. Fitzgerald has been talking about, which is a free flow of information among clinicians to enable them to better understand the crisis that they're dealing with and respond appropriately. So it's, you know, on the ground in two places. On the ground in terms of public authority in the states, trying different things as public health. But ultimately, as a matter of medicine, you're dealing beyond public health. You're dealing with clinical achievements, and that ultimately depends upon, once again, the professionalism of doctors, their ability to communicate with each other and to cooperate and collaborate and work to fight this disease.
Wonderful. We have a question specifically for Dr. Gallagher. Based on your experience, how would you rank different comorbidities in terms of their adverse outcomes among infected patients?
That's a great question, and I'm not sure that I would necessarily rank them, but I would say that definitely congestive heart failure, COPD, diabetes, as well as obesity. Those are probably the top four, and those are the ones that I look for because it seems like those patients do worse. And especially with obesity, there's been a lot of link with a hyperimmune and hyperimmune system. So that's one that I typically wasn't on my radar as a critical care doctor, but for COVID-19 patients, I certainly look at their BMI, and that goes into a factor when I'm deciding, is this someone that's at risk and or not?
I have a question. If I just want to ask one question, and that is, this gets to the heart of why this is so critical for the general public. In terms of your experience in the ICU, supervising 20 physicians dealing with this problem, how many patients, roughly as a percentage, how many patients going into the ICU actually have, based on your testing, based on determining the markers, right? How many actually have this autoimmune response that is so deadly, roughly?
Bob, I would say the vast majority of the patients that we had in the initial phase of it, where there were community, where there were healthy patients that were coming in, maybe they had diabetes, maybe they had obesity, but the vast majority that were coming into our ICU were due to the autoimmune, the immune-mediated process, and not necessarily the virus itself. Now, at this point, since we've had a shift and 80–90% of the people that I'm seeing in our hospital now are from nursing homes, and that kind of changes the dynamics. And those patients do come in because of the virus and what the virus causes in terms of a COPD exacerbation or a congestive heart failure exacerbation. But the large majority of the patients that were initially seen in both of our ICUs were due to the immune mediated. And I would say probably 90% that were on ventilators was due to the immune mediated disease and not necessarily the virus. And that was profoundly shocking.
Dramatic information.
Dr. Fitzgerald, this might be a good question for you. There's been discussion now about the nursing home situation across the country. Are there things that that at the state level that should have been done or states should be doing to make sure that they begin to kind of put a cap on what's going on in the nursing homes and make sure that this doesn't continue to perpetuate the cycle? You might be on mute.
Thank you. Absolutely. And the problem, of course, in the nursing homes, a lot of those patients are not healthy to begin with. So for a lot of those patients, any kind of change or any kind of additional insult can result in severe morbidity or death. It's just like Dr. Gallagher was talking about. Those patients really are a separate subset of patients. So we know that this virus is easily transmitted, and we know that if they get it, it can be deadly because they already have pre-existing conditions. So the states really need to step up their oversight of nursing homes and make sure that we basically know how this disease is transmitted. It is transmitted by droplet. So we know that face shields and masks and gloves, because we know it can survive on inanimate objects. We know that. So if we go into nursing homes, and one, we really need to decrease or absolutely regulate people who come in to visit nursing homes. And then we need to absolutely regulate the people who are working in nursing homes so that we know how it's transmitted. And I think that with that, we can get a handle on the disease in the nursing homes.
Nina, if I can also add to Dr. Fitzgerald's comments. Very early on in our process, there's a Jewish home for the aging, which is a very large nursing home that's within a few miles of our hospital. Dr. Marco Noah, who's their CMO, reached out to me very early on to kind of ask me what we should be doing, what we should done. And they started a very, very rigorous screening process for all of their nursing, all of the staff. They also put in a very strict limitation in terms of their visitors. And they have hundreds and hundreds of patients that they take care of, whether they're in assisted living, whether they're in nursing. And they've only had a few handful of patients that have acquired it, versus other smaller nursing homes in the area have had large outbreaks of 20, 30% of their patients developing COVID-19. So it really makes a difference in terms of what is done. I've spoken to other nursing homes where they don't have the PPEs for their nurses, and we've seen a lot of outbreaks in nurses in those institutions, as well as their CNAs that help take care of the patients. So as Dr. Fitzgerald said, this is a very, very contagious virus, and we need to treat it on all fronts. And what happens in the community is not necessarily the same thing that's happening in our local nursing homes. So we need to have a two-front approach to treating and taking care of those patients and preventing it from spreading.
Great. This is, I don't know if you guys have a comment, but it was a curious question for me. With all the different treatments going on out there, are there any concerns about liability for wrongful treatment that you're concerned about moving forward with things moving so quickly and doctors really practicing on their feet? Are you concerned about that? Is there anything you think that could be done to make sure physicians are protected from that?
From a doctor on the front line and speaking to other doctors, that was absolutely one of their concerns. Doctors did not want to initiate any therapy that was not part of a randomized control study from NIH or a guideline that was handed down by CDC. From my own personal perspective, I did not give a single medication to a single patient until I understood the disease process. And even then, when I started understanding the disease process, I made sure that I informed the patient. I made sure that I informed the patient's family. I also obtained other physicians, rheumatologists, hematologists that were not part of our core team to help guide the therapy. So yes, it's something that's definitely out there, and there is a fear and there is a concern. But from my perspective, I'm a physician. Above all, I have to treat the patient. And if I understand the disease process and I understand how to treat the patient and it's not going to harm them, I don't understand how I can withhold therapy. I think from my perspective, that's a worse evil than to give therapy. So I try to make sure that everyone is informed as possible and only treat those patients that need it. And again, we've had 260 patients that have been admitted to our hospital, but I would say out of those 260 patients, probably only about 40 or 50 have been treated with these types of parodies. We're not blanketly giving it to everyone that comes in. And I think that's one of the problems with the randomized control studies, is that they're not differentiating between the COVID-19 where the virus is attacking them versus the COVID-19 patients where the immune system is attacking them. And that's why we're seeing all these randomized control studies not produce any positive effects.
But you're right, Nina, about one particular thing. This is a new virus. When it says it's a novel virus, that means we haven't seen this one before. So it is impossible to have an we can start with what we think our understanding is, like we started with our understanding that this was a solely viral respiratory disease. But we have no knowledge about treating this disease before. So inevitably there will be things that we have to learn by trial and error. And that's again why it is so important to have this national conversation. Because the national conversation, we can take the 200 patients in your hospital and the 1,000 patients in a New York hospital, and the patients all over the country, accelerate our understanding of the disease. Very, very important.
That's great, because it leads into another question, which is, what are medical professional societies doing, or should they be doing, to organize and facilitate this exchange of information?
I think,
I know
go ahead.
No, go ahead, Brenda. I'm sorry.
I think that we simply need to have them do it. This is a just do it situation. Whether it's done by the CDC, which I think would be fabulous, whether it's done by the AMA, I think that would be fine. There needs to be a national entity that steps up and said, okay, we'll take this on. We will make sure that we get this conversation going and we keep it going. And I know certainly from the infectious disease people here in my hometown, they would welcome that because right now we really, again, this is a new disease. It's been in our country for 4 months. It was in the information we have coming out of China is not that much older. So we really need to have a national discussion. I'd absolutely support the AMA doing it. I would support the CDC doing it. I just think there needs to be a national discussion.
Yeah, and I couldn't agree more with Brenda. There's definitely a hunger, a thirst, and a desire to have best practice guidelines. Now, we're not going to have randomized control studies, so we're not going to have protocols, but we should have best practice guidelines. And I think it would alleviate a lot of the physicians on the front lines and a lot of their concern about, malpractice and practicing, on their own. If there was an entity, whether it's CDC, AMA, where they can produce a best practice guideline, a living guideline, because, again, over the past 6 weeks that we have been treating these patients, it really changes because, again, it needs to be individualized therapy. There isn't a one size fits all. So if there was a large entity, a large organization that came out with the best practice guidelines, I think that would really be helpful to us frontline doctors.
What I was going to say is there is some good news here in the sense that there seems to be a growing understanding of this. Back when Dr. Yedigar, if my recollection is correct, Dr. Yedigar was talking about this with us in early April, but Lancet came out with a disease progression discussion, which was virtually identical. And the same thing was happening with doctors in Virginia who were coming up with the same findings with regard to COVID-19 and the autoimmune response. The problem is, and I think Dr. Fitzgerald points this out very well, we can't depend upon, articles in professional journals to give us direction in the midst of a national crisis. We've got to be able to move much faster than that. It's great that Lancet came out with, thank God, that Lancet came out with that outline that basically confirmed what Dr. Yadigar was telling us. We have to have a much more rapid and flexible response in the midst of a crisis. And I think with the medical profession, perhaps a combination or partnership between the medical profession and CDC, we can maybe design a protocol, not for this particular disease, but a protocol that can enable members of the medical profession and clinical practice to be able to move quickly with some assurance that there's a corporate strength behind them when they're starting to move in this direction, because obviously we can't wait for randomized studies, you know, in the midst of a national emergency. It doesn't work.
Well, we have time, I think, for 2 questions. And one is a very technical question that Dr. Gallagher has been directed at you. And then we have a general question that we'll wrap up the panel with. Dr. Gallagher, if you're comfortable, here's the question. Do you use prednisone in the ICU for the immune response? And do you use, I might mispronounce this, glutathione, which cools off the immune system? Can you comment on that?
Sure, of course. We did try to use IV corticosteroids, prednisone being an oral form of it, and we really didn't see much of a response. This is the immune mediated is acting through T cells, which are a little bit different, and they don't respond to they're not steroid responsive. That's why you've heard of all these other medications such as interleukin-6, which are really inhibiting the cytokines that these T cells produce. This is a self-directed and feeding loop. So if you can slow down the cytokines that these cells produce, then hopefully the process will kind of wind down by itself. If you don't, then it just kind of feeds itself and just goes on forever and ever in a small minority of the patients. And no, I have not used glutathione, and I comment on that.
Okay, so our last wrap-up question, I think, is very appropriate. As we said, we have medical professionals on this webinar, but we also have a lot of Americans who are just interested in what's happening in this area. And so one of the questions that has come in is, and it's a good reminder for all of us, what can we do as states are beginning to open up? What can people do in their daily lives to help in this situation? And how can we best make sure that as we are opening up carefully, that we are taking responsibility and really being self-aware of what we're doing?
First of all, even though we are increasing our activities outside the home, we certainly need to remember that this is indeed a disease that is very infectious, easy to catch, and we need to keep up those things like face coverings, wear gloves when you go to the grocery store, wash your hands, all those kinds of things that we've been talking about before. Those, even though we open up, we need to absolutely continue that because this is a very infectious disease.
Wonderful. Dr. Gallagher, is there anything you'd like to add to that?
I would. I think, the one thing is that, as this has been said over and over, this is a local disease. It happens in clusters. So even within a city, there will be areas that are hit harder than other areas. And we really need to have our local officials be very, very in tune with our hospital systems. The 2 most important factors in terms of opening up, the country is, one, to try to decrease the rate where this virus is, passed on. And as Dr. Fitzgerald said, it's incredibly contagious. So that's the first thing is, when we see that there's an outbreak, we need to be able to quickly move to kind of, stop it from further propagating. And then second thing, and probably equally as important, is to make sure that when there is an outbreak, the hospitals in that local area are not going to become overwhelmed. The quickest way to raise a patient's mortality numbers is to keep an ICU patient in the emergency room. Our emergency room is excellent. They're great at, our physicians are amazing. They've been on the front line. They're great at triaging. They're great at treating these patients, but you don't want the hospital to get overwhelmed, and you don't want these critically ill patients to stay in the emergency room for days and days. That's the quickest way to increase their mortality numbers. So as long as we have those 2 focuses, where we try to cut down the transmission and then make sure that the hospitals in those local areas are not overwhelmed, I think we can do this in a smart way and continue to save lives.
I would just simply add that I have nothing to add to the quality of that conversation, except to say this, that we know enough about the virus now to exercise common sense. The data shows that overwhelmingly the most vulnerable people are those who are over the age of 65 and who suffer certain comorbidities, respiratory, pulmonary, cardiac conditions, as well as obesity and diabetes, we know. So therefore, public health authorities should really focus on protecting those groups as much as possible. They, at the same time, generally speaking, I think that we should recognize the fact that younger people, generally speaking, who are in good health without comorbidities, should have the opportunity to go back to work. And many of them will be able to weather this storm. They'll be able to, be able to work and not be faced with death as an option. At the same time, they got to recognize that they've got to take care of their fellow citizens who are older, those who are vulnerable, those who are over 65, certainly.
Well, I want to thank our speakers for sharing their time and their really valuable insights. It's been an amazing discussion. As I tried to navigate through the questions, if I didn't get to your questions, don't worry. We'll be passing on those thoughts and insights onto the virtual clinical cabinet, and hopefully it will help inform some of their work moving forward. In the meantime, if you are interested, you can get more information about the National Coronavirus Recovery Commission at heritage.org/coronavirus. And I just want to conclude by saying again, thank you for joining us, and we will end this webinar now at this point. So thanks for coming on.
Thank you.
Thank you. Thank you for having us.